Good evening, everyone. I am Dr. Mohammad Shah Alam, a medical doctor from a small village of Bangladesh, Shahjatpur, Sirajganj. I have completed my Bachelor of Medicine and Bachelor of Surgery degree from Mymensingh Medical College, and has had the privilege of working in Dhaka Medical College, Bangladesh. Now, I am working as a senior consultant in AWCH, Dhaka. But my thesis was conducted in Jaipur Clinic and Diabetic Center, a rural population. I chose the rural area because the rural population are mostly neglected in our Bangladesh, especially in case of diabetic mother and diabetic care. And I think that this neglected person, neglected community is not only in the Bangladesh, all over the world, rural communities are neglected and faces the same challenges. For this reason, I would like to present these cases with the title Impact of Risk Factors for Gestational Diabetes on Pregnancy Outcomes in Women with GDM in Single Center Study in Rural Area. We know GDM is hyperglycemic state in during pregnancy and most of the common obstetric complications. It is a metabolic disorder occurs in during pregnancy. Both GDM and advanced stages increases the risk adverse pregnancy outcomes. Diabetes detected in the second and third trimester of pregnancy is not clearly classified as type 1, type 2 diabetes mellitus. They are mostly known as GDM. Globally, the prevalence of GDM is rising in tandem with the growth of obesity with type 2 diabetes mellitus. GDM complications, about 7% of the pregnancies, overall about 2 lakh cases every year. Depending on the population under study and diagnostic procedure used, the prevalence could be anywhere and from 1 to 14% of all pregnancies. Recent changes to diagnostic criteria has resulted in a lack of agreement over which criteria should be applied. Pre-pregnancy, overweight, obesity, advanced mother age, and family history of the diabetes mellitus are well-established risk factors for GDM. One of the primary risk factors having GDM is thought to be ethnicity, especially Australians, African Americans, Native Americans, Asians, specific islanders, Hispanics are among the ethnic groups thought to be at a greater risk of developing GDM. Women from the South and Southeast Asia are often seen as being to be higher risk. Hyperglycemia and adverse pregnancy outcome studies large-scale multinational cohort study involving 25,000 pregnant women, which showed correlations between the glycemic levels and higher risks of obstetric and perinatal morbidities. It is sole source of data. The recently suggests International Association of the Diabetes and Pregnancy Study Groups approach suggests measuring fasting 1 hour and 2 hours glucose level or administering of 75 gram of 2 hours OGTT are classified any single aberrant value as the diagnosis of gestational diabetes mellitus. Short-term negative consequence of the mother, hypertension, preeclampsia, cesarean section, and preterm delivery, and her children, like shoulder dystocia, birth trauma, neonatal jaundice, respiratory distress, and neonatal hypoglycemia are linked to gestational diabetes mellitus. Long-term consequence of moms with GDM include elevated risk of GDM recurrence, type 2 diabetes mellitus, hypertension, cardiovascular disease. Furthermore, diabetes during pregnancy may raise the chance of obesity of type 2 diabetes mellitus and offspring later years. The retrospective observational study set out to determine how to risk variable taken into account for selective screening affected clinical and biochemical markers as well as outcome of both mother and their fetus in pregnancies complicated by gestational diabetes mellitus. The aim of the study was to evaluate the impact of risk factors of gestational diabetes mellitus on pregnancy outcomes in women and with GDM. It was a descriptive cross-sectional study and it is done in the Jaipur Clinic and Diabetic Center, Dhaka. The study was from July 2017 to June 2023. The study population was total 143. After collection of data was checked and cleaned and followed by the eating, compiling, coding and categorizing according to the objective and variable was detected errors to maintain consistency, relevancy and quality control. Statistical evaluation of results used to be obtained via the use of Windows-based computer software program devised with statistical package for social sciences. No confounding variables are considered for the study at the time. The selection criteria, women with gestational diabetes mellitus, was inclusion criteria, and the patient who was not willing to give the consent was excluded. That was exclusion criteria. There is a lot of variables like age, occupation, education, residence, BMI, parity, gravity, antenatal care, gestational age, LDH, HDL or triglyceride, OGTT, first hour, second hour, birth control, fetal outcome, a lot of. We discuss about the results. The observational cross-sectional study was conducted in Jaipur Clinic and Diabetic Care in Bangladesh. Patients who matched inclusion and exclusion criteria was approached to participation of the study. Patients who are not willing to give consent was excluded. Purposive sampling was done according to the availability of the patients who fulfilled the criteria. After fulfilling the exclusion and inclusion criteria for the purposive sampling method, a total number of 143 apparent patients were included in the study. We see here the distribution of the study population according to the age. We are seeing the service holder is more, 55%, and housewife was less, 44%. And distribution of the study population according to the education, we are seeing that the graduate was more, 26.8%. And here we see the BMI and the distribution of the patient according to birth weight. We are seeing there is a average birth weight is 30%, low birth weight is 44%, and very low birth weight was 24%. The distribution of the patients according to the obstetric parameters, Nalipera was 45.9%, and multigravida was 58.5%, and regular antenatal care was 50.3%. And there is a P-term, gestational age was 61.2%. We have seen that a lot of P-term baby was done in case of gestational diabetes mellitus. Distribution of the patients according to clinical parameters and laboratory parameters. We have seen that blood pressure was controlled, and laboratory parameters we see the total cholesterol and triglyceride was elevated, and HbA1c was controlled. The distribution of the patients according to maternal outcome, we have seen that insulin therapy was taken 47.5%, and there is a cesarean section was done 64.5%, preeclampsia was 6.6%, anemia was 8.7%, postpartum hemorrhage was 4.4%, and abnormal fetal position was 9.3%. Preterm birth was 11.5%. Here, the distribution of the patients according to fetal outcome. We have seen that hypoglycemia was 9.8% and hyperbilirubinemia was 4.9%. There is a respiratory distress syndrome was 13.7%. Need admission to NICU was 18.6%, and neonatal death was 1.6%. I think it is not less. Conclusion. It was found that as BMI had the biggest effects on the success of pregnancies in GDM patients. According to this perspective, it was important to identify the risk factors at the time of diagnosis or even earlier in order to better to tailor the treatment of the illness and avoid negative consequences. Limitation of study. The findings are based on the data from the rural healthcare facility, which may limit the generalizability of the results to other regions or populations. The study population may not have large enough to detect all possible associations or their outcomes. If some data was collected from the medical records, there has been incomplete or missing information leading to potential bias. Factors such as diet, physical activity, socioeconomic status were not fully adjusted for which could influence both GDM risks and pregnancy outcomes. Outcomes were likely assessed only during pregnancy and delivery without long-term follow-up of maternal or neonatal complications. Some data like lifestyle, family history might be subject to recall biases. The findings may not be applicable to urban or higher resource settings where healthcare access and lifestyle factors differ. So this is our recommendation. The implement routine GDM screening during early pregnancy in rural healthcare settings to enable timely diagnosis and intervention, educate women of reproductive age, especially those with known risk factors, especially obesity, family history of diabetes, advanced maternal age, about preventive measures before conception. Further research, conduct larger multi-center studies to validate findings and improve the generalizability of the results across different populations. Thank you all.
Thank you very much for this important presentation. Well, I have a question. You mentioned that I think 118 patients undergo C-section. Why was that?